Hello everyone, this is Dr. Sandeep Badan. I put certain questions for revision on upper limb topic today on my Telegram group. So I'm going to discuss those questions with you guys now. And this is I'm sharing with you guys my Instagram, YouTube, and the Telegram group details. So let us start the discussion. This image was given and one muscle is marked. We can see this is the medial border of the scapula, right? And in this medial border of the scapula, what muscles are visible? This will be levator scapulae muscle, and this will be rhomboideus minor muscle, but which one was marked is rhomboideus major muscle. What is their action was the question, right? So if I ask you single best answer, then answer will be retraction, but we will write retraction in this manner. Why? So that we can remember retraction will be done by R for rhomboideus along with T for trapezius. So rhomboideus plus trapezius together do the retraction, and that will be the single best answer. But here we have to choose the answer among like given combinations. So it will do the retraction. That's definitely it is going to do the retraction with the trapezius. Yes. It will also do the elevation. Yes. It will also do the elevation. But look at the elevation. Is it doing elevation in this direction or in this direction? It is going in oblique direction because this is the direction of the muscle fiber. So if it goes in an oblique manner, the glenoid cavity will tilt downward. Because of this pull in an oblique manner, the glenoid cavity will come downward. So overall we can say retraction, elevation and rotation in such a manner that glenoid cavity will tilt downward. So A, B and D. That's why B is the correct answer. Next question, if occlusion occurs at the second part of the axillary artery, how the blood flow will be maintained? We know there's an anastomosis around the scapula between the branches of subclavian artery and the branches of axillary artery. So among these options, answer will be C, deep branch of the transverse cervical and the subscapular artery. Let me show you this image which will help us understanding. We can see this is the branch which is deep branch of transverse cervical. When it comes down, it anastomoses with the branches of subscapular artery, and there is circumflex scapular artery which anastomoses with the suprascapular artery. So these are the two major anastomoses around the scapula. Sometimes instead of deep branch of transverse cervical artery, there can be dorsal scapular also present, because in one individual either of these will be present. Either it will be dorsal scapular artery or it will be deep branch of transverse cervical artery, but whatever will be present, it will be making an anastomosis with the subscapular artery. So that is why we got our answer. Next, this test. What is this test? Card test. One card has been put in between the fingers of a patient and the patient is applying the adduction force. So what does the adduction? Palmar interossei do the adduction. This is for pad. There's another type of test which is called as Igawa test. Igawa test, we test the dorsal interossei where we check the abduction of the dorsal interossei muscle of the patient, right? So basically, whether it is a Palmar interossei, CAR test, dorsal interossei, Igawa test, in fact, the book test, which is tested for the adductor pollicis, Froment sign, all these are for ulnar nerve. Now something has been marked. What has been marked? We can see this is the cubital fossa, where we have this structure which is marked is the median nerve. This is the median nerve. And then we have the brachial artery, right? Brachial artery. This will be the biceps tendon. Okay, we can see the biceps over here. And this will be the superficial branch of radial nerve. So we have the mnemonic MBBS and median nerve has been marked. And the question is, in case of compression of this, what will happen? Straightforward answer, ape thumb deformity. Claw hand will be seen. Complete claw will be seen in clump case palsy, and the partial claw will be seen in case of ulnar nerve involvement. Horner syndrome is because of the ocular sympathetic T1 fibers involvement, and the wrist drops or loss of extension will be because of the radial nerve involvement, right? Next question, the patient has got some chronic history of the shoulder pain, and you have suspected the tear in the supraspinatus. Now, what is the action of the supraspinatus? The initiation of the abduction, particularly 0 degree to 15 degree, it plays a major role. That's why that will be the answer. Straightforward question, right? Identify the marked muscle. Let's look at the given image. This was the given image. Now, first of all, you check this level. This is the elbow level. Okay. Just behind the elbow, if you see the triangular muscle, this will be anconeus. But above the elbow, we have two muscles. I'm writing here. I'm showing you this A and this B, which has been given. These two are coming from above. But if you see, A is still higher, that will be brachioradialis, and the lower one, which is coming down and crossing this carpal bone, just getting attached to metacarpal. If something is just crossing the carpal and just getting attached to the metacarpal, it will be carpi muscle. Okay, so that will be extensor carpi radialis longus. But I'm saying A muscle is brachioradialis, then where it is going? The term is brachioradialis because it starts from the brachium arm. That means it is coming from the humerus bone and it is ending in the radial bone. It is ending at the level of radial styloid. So from the brachium up to the radial, that's why the name is brachioradialis. It will not be able to cross the carpal bones. If it is crossing the carpal bone, either it has to be ECRL or ECRB on the radial side or ECU on the ulnar side. I hope that gives you the identification criteria, how to proceed about it, right? So what will be our answer? ECRL. Next, move on to this question number 7. One muscle has been given. First, let's look at the muscle. We can see this muscle is brachialis. Why? It is coming from above the elbow, from the front. It can be either biceps or brachialis because coracobrachialis will not cross. But it is getting attached to ulna. So brachialis will attach to the ulna. Biceps will be attached to the radius. Okay, so this is a brachialis muscle. Now, if it is brachialis, it is making the floor of cubital fossa. True. Supplied by median nerve. Not true. And that is false. That's why B will be the answer. It is attached to ulna. Yes. It flexes elbow joint very much. Next question. The patient is having some shoulder pain and there is a flattening of the deltoid, and above the deltoid the skin is also losing the sensation. That means there is deltoid palsy. Axillary nerve is gone basically, right? Axillary nerve gone, it can be various reasons, but among these given option, anterior dislocation of the humerus can justify. Other reasons can be like there can be injury to the surgical neck of the humerus fracture, okay, or sometimes irreverent site of injection that can directly injure the axillary nerve. So those things are also possible, right? Anterior interosseous nerve. What is this nerve? This is a deep branch of median nerve. Now, where is the median nerve territory? Forearm anterior aspect is the median nerve territory. But we are looking at the deep branch. It must supply deep muscles of front of forearm. So we are looking at flexor pollicis longus. Yes. Flexor digitorum superficialis? No. It has to be profundus or pronator quadratus. Which of the following structure is in the scapula is palpable? So this is a factual question, but this question was long back, it was asked, and in the recent years also it was asked. So I have put this question just for practice sake. And answer is C, coracoid process. That we need to remember. It's a factual thing. Coracoid process. Now this particular question, whenever you come across such type of question, I know that by this time you must have already remembered. Fall on the hand, fall on the outstretched hand, snuff box tenderness. Which bone we are worried about? Scaphoid. Because of its poor blood supply comes in retrograde manner, and chances of non-union or delayed union or those type of complications are possible. Okay. Next question. Again, there's a fall, there's a history of the fracture, but fracture leads to the laceration of the nerve. What really happens? The patient has lost the ability to extend. So extension is lost. As a whole, extensors coming from the elbow, wrist, everywhere. Extensors are by and large supplied by radial nerve or its branches. So we are looking at radial nerve because also they are saying numbness in the skin of anatomical snuff box. There also we have a branch of radial nerve. So which artery will share the course? Straightforward, profunda brachii is the one which shares the course with the radial nerve in the spiral groove or the radial groove. Which of the following supplies the marked muscle? Let's look at the muscle here. Now this is something marked. Before that, let me tell you, if we are looking at this the thumb side, so this will be abductor pollicis brevis. Inside it will be flexor pollicis brevis. On the hypothenar side, it will be abductor digiti minimi, and this one will be flexor digiti minimi. Now, where I'm showing you these dots, these are the deep muscles, these are the deep tendons, because just above them, if I show you these lines, these are present over these dots tendons. So dots tendon are below, these are above it. Above means superficial, which have been reflected. So these have been reflected, these are superficial, but the dots are FDP, flexor digitorum profundus. And from the profundus, these muscles 1, 2, 3, and 4 lumbricals, they take origin. So now by going in a methodological manner, we have reached which muscle has been marked. So dear friends, it is the second lumbrical. We know lumbrical 1 and 2 are supplied by median nerve, and lumbrical 3 and 4 are supplied by ulnar nerve. So because it is lumbrical 2, answer will be median nerve. Next question, what is the false about the marked muscle? Let's look at the marked muscle. Here we can see this bone is ulna, this bone is radius, and this muscle is taking attachment from radius, ulna, and also interosseous membrane, which will be present between the two bones. And then it is coming up to the base of the first metacarpal. It will be abductor pollicis longus. Apart from these muscle, there will be two more muscles which will make the boundaries of the snuff box. Let me add. One will be coming from the ulna and membrane, the other will be coming from radius and membrane. Now you apply your common sense and tell me which one will be brevis, because one of them will be brevis, other will be longus. Which one will be brevis? Brevis means short, the one which is coming from nearby. So which bone is nearby with respect to thumb? Is it radius or ulna? Obviously radius. So the one which is coming from the radius will be reaching up to this point, and this will be extensor pollicis longus, extensor pollicis brevis, and the one which is coming from the other side, it will be extensor pollicis longus. Now we can see these two are making one boundary together, and alone extensor pollicis longus will be making the posteromedial boundary. Okay, so we can see anterolateral aspect, it makes the boundary. Yes, it is supplied by posterior interosseous nerve. Yes, that is true. It will be attached to ulnar, radius, and interosseous membrane. Yes, we have seen this marked muscle was abductor pollicis longus, and all the points are with respect to that muscle only. But can it flex the wrist joint? No, it is not going to flex. It is abductor of the pollicis longus, right? So now the last question, there will be right hand clumsiness, so some motor deficit is there, and there is loss of sensation on the fifth finger, hypothenar eminence is flattened. So we are looking at ulnar nerve. This all is the distribution of the ulnar nerve, and among these it may get fractured, it may get injured in case of fracture of hook of hamate because it passes beneath it. Let me show you. Here you can see it is passing beneath the hook of hamate. So in case of fracture, ulnar nerve may be involved. So that was all, dear friends. Thank you so much. Keep in touch. Thank you. God bless you all.